started we just started 5 minutes late, so we could allow the other people to also join up. Today we have our third session that will be on introduction to communication in the context of pain. This is something that's like from the first day onwards, we have been stressing that one of the most important things in controlling pain, as well as in basically any treatment for any form of medicine, is communication. So today we have a very eminent personality. I am fortunate to have attended his class the last time when I was a participant in this session. So I'd like to introduce to you Dr. Biju Raghavan. He's a senior consultant and head of department of the Pain and Palliative Medicine Department at Rajagiri Hospital, Aluva, Ernakulam. He is practicing palliative care since 2003 for the past 17 years. He's part of the first batch of the first PG diploma in pain and palliative medicine program in the country. He's also a visiting faculty to TIPS Trivandrum, MNJ Institute of Oncology and RCC in Hyderabad, Department of Physiology, Kerala University in Trivandrum, and Rajagiri College of Social Science in Ernakulam. So as you can see, he has experience teaching through the length and breadth of the country. The areas of interest include communication skills, oncology and respiratory palliative care, and end-of-life care. So without much further delay, I'll hand over the session to you, Dr. Biju. Please take over.
Thank you, Dr. Ashok, for the extremely kind introduction. Much honored. Thank you, Palim India, for continuing to call me for your teaching programs. It's a pleasure being part of the Palim India family myself. With that, welcome to all the participants for today's session. It is just a general session on communication skills. I'll be talking about a few things here and there. Nothing in very depth, but just trying to cover a few things. I'll share the screen. Okay. Okay. So today we will be covering upon some basic things like body language and spoken word, just 1 or 2 slides each. A little bit on communicating bad news, some of the disclosure models that we practice, and why it should be broken at all, why bad news should be broken at all. A few thoughts on that. We will deviate to collusion, just 1 slide on collusion, because it is something that we all have to face on a regular basis. Then after that, we'll come back to communicating bad news. This time, some practical aspects of it. And then we'll round it off by talking about anger in a clinical situation. So non-verbal aspect of communication is very important because one, it forms the major component of any communication, personal communication, professional communication, any kind of communication. The non-verbal body language constitutes the major component. Many research studies have come up that on an average around 70% or more is body language of any communication. But the problem with that aspect is that many times we are ourselves not very aware of what our body is doing. We are not body conscious. We are not attuned to how our body is behaving when we are having interaction with another person. So are we making enough eye contact? Are we smiling enough? What's the facial expression? What's the tone of the voice? All kinds of things. We're not going into the depth of it because today's session is not meant for that. However, I would like to talk about a few things over here. You see here, there is a medical professional standing by the bedside of the patient, and you can see for them to make eye contact, this patient has to turn the head, uh, so that after some time, it will become uncomfortable for this person. Instead of standing here, if the healthcare professional was standing somewhere near the foot end of the patient, then this patient could have had eye contact in a more comfortable manner. So when you enter into a patient's room, first position yourself somewhere here. This is the time to say hello, how are you, things like that, the greeting part. So if you position yourself over here, then you can have a patient who makes an eye contact comfortably. Coming to this picture on the right side, you can see a healthcare professional sitting nearer to the foot end of the patient. And you can see because the healthcare professional is sitting near the foot end, the patient can comfortably make eye contact, right? And compared to standing, sitting gives more satisfaction to the patient and family. Just imagine if some guests come into your house. We are talking about the pre-COVID era. If some guests come into your house, if they stand and have tea and then go away, will that be satisfactory? You would want them to sit down, have a conversation while you host them. So the same effect. If you stand and meet the patient standing, and if you meet the patient sitting and having conversation, spend the same time. If you spend 2 minutes or 3 minutes per patient in your morning rounds, just sit down and spend that 2 minutes. You will see there's a substantial improvement in satisfaction of the patient and family. Then when it comes to children, you can see this gentleman here is bent at the knee so that the eye contact is at level, right? So whether it is adult or children, we should always position ourselves in a way that we are at eye level. For example, if the patient is standing, you just stand up, eye level. If the patient is lying down or sitting, you pull up a chair or a stool, someplace you sit down, it will be eye level, right? So eye level creates equality, sitting down increases satisfaction, and positioning yourself at the foot end will give more comfortable eye contact. So there are plenty other things in body language. I'm not going there. Just coming to one or two verbal do's and don'ts. First and foremost, the most important don't is do not assume. Many times we have occasions where patients may say something, sometimes with a lot of emotion, and we will assume they're saying that because the because is something the filled by us, our assumption. The simplest way of not assuming is to ask the person, why did you say that? And they will tell you. It's as simple as that. However, we are just not trained to, ask uh, this kind of questions. And it is not just about medical profession. Assuming is rampant across the board. So it is, but when it comes to our profession, there can be a lot of problems if we end up assuming something. It's always good not to assume. Second, especially since we are talking to oncologist here, sometimes it becomes very difficult to be honest. So if you can't tell the truth, at least don't lie to them. So there is a lot of gray area in between. And something very close to that is hope. We all understand the importance of hope, but giving false hope is really terrible because it will break, eventually, it will break the patient's heart, it will break the patient's trust in you. So, what you need to do is to give realistic hope. For example, many times when I am dealing with patients, which many of you, a medical oncologist, may send to me because it is, no further, even palliative chemo is no longer feasible. And then they send the patient to me, and I usually end up telling them, the patient, that see, the disease is fairly progressive and they have tried their best. Uh, in your best interest, your medical oncologist feels that chemo should not be proceeded. So that means further disease management may not be possible. However, I am here. I'll make sure that you do not suffer. And I will take care of your difficulties. I will make sure you are comfortable as long as you need me. So the messages that I'm conveying is that this is not a situation where nothing else is to be done. There are still things to be done. Second message is we will ensure that you are comfortable. The third message is I will not abandon you. That means that is these messages are given, not verbally but between the lines. That I am available as long as you need me is saying that you can come to me any number of times whenever you want, as long as you want. So this kind of messaging is something that we can give, because that is something we can realistically give, right? For example, a pain management, cancer pain management is really not a difficult thing. It's quite easy actually, and you can keep somebody pain free till the last breath of their life. It's not a big deal. Similarly, we can keep them relief. We can provide relief of breathlessness, delirium, restlessness, anxiety, depression. All of these things we can realistically we can provide. So there's a message that needs to be given realistically, and that messages needs to be given. So there is no hopeless situation, only that we have to differentiate between what is realistic and what is falsehood. Coming to breaking bad news, truth telling, essentially that is truth telling, is never easy. And as a result, we have some not really scientific. One of the models that we use in our environment, mostly Oriental culture, Asian culture, Indian, is a non-disclosure model. That is, we talk to people, but we never want to talk to me. So we may have many reasons why we don't want to disclose bad news uh, to our patients. Different doctors have different reasons. I just put in a couple of reasons over here. But the problem is this can get into a conflict with a patient who wants to know. Because if the patient wants to know, then the patient has the right to know. And people may want to know for very many reasons. Because they may want to plan something, or they just want to know because they feel it is their right to know. It could be many, many things. So when we practice non-disclosure model, it comes into conflict with the patient's right to know. Then there are some places where you talk to the patient and you can talk to the family only with the permission of the patient. In those kind of environments, many a times developed Western countries, where you have to communicate the truth, even if it's a bad news, to the patient and to the patient only. In that kind of situation, we practice full disclosure model. And sometimes in our environment also, some of the doctors may decide that is the right thing to do. I will tell all my patients what is the truth. I will communicate bad news to all my patients. This is my policy. So some of the doctors in our environment also may practice like that. The problem with that is it gets into conflict with the patient who does not want to know, or at least does not want to know right now. So the problem is that the patient has the right not to know as well. And the patient has the right not to know as well. And the patient may not want to know for various reasons. They're just not mentally prepared, or they couldn't be bothered with it. There could be any number of reasons. So the these two prevalent models of non-disclosure model, full disclosure model, both gets into conflict with patients, because patients are individuals, and individuals have individual choices, they have individual thinking, they have individual ways of opinions of how these things should be dealt with. Therefore, we need to make an individualized disclosure model. Basically, that means we need to first figure out the person sitting in front of you, whether that person wants to know or not. First point. The second point is, if the person wants to know, really wants to know, then how much the person wants to know. So first question, if the person wants to know. Second question, how much? Now that basically sums up the individualized disclosure model. Now, how we go about it is it's a different thing. We'll come to that later. First, let's talk about why it is important to communicate bad news. First and foremost, uh, I have 3 points in front of you, the 3 bullets. The first and foremost reason why it is important to communicate bad news is it gives a chance to the patient to finish whatever he or she wants to do while the person has reasonable physical and mental health and energy remaining. So, of course, when the person knows it, initially there can be shock, there can be denial, there can be anger, there can be bargaining, there can be depression. Ultimately, we expect the person to come to terms with his or her reality, and then the person will think, okay, I am in the situation, what do I need to do? So this involves a lot of things that involves finishing finances, plans for children's future, the things that I wanted to do but never got time for it. Example, a bucket list. Improving relationship, strengthening relationship, telling how much I love you, and also mending relationship by, in case you did something wrong and you may want to ask for forgiveness, or if somebody did wrong to you, you may want to give forgiveness. Just lighten the burden, lighten the load on your soul. Another problem that I would like to highlight is hospital hopping and doctor shopping. So if the patient does not know what is the problem, just like you and me, the patient has a life to live. The patient wants to get back to normal life. The patient is saying, I'm spending so much of time, energy, and money on this test, this investigation, that investigation, this treatment, that treatment. Why am I not getting better? The patient's expectation from our point of view may be unrealistic, but from the patient's point of view, we are not reaching up to his or her expectation. And it's not the patient's fault, because the patient does not know the reality. We know the reality, some of the patient's family members know the reality, but the patient does not know the reality. So as long as the reality expectation mismatch persist, we are never going to give satisfaction to the patient. And if the patient is not satisfied with our treatment, the patient will lose our trust. The patient will lose faith in us, our institution, and will demand from his or her family, take me to some other place. The family cannot say, no, no, you stay here. And then the search for a good hospital, a good doctor, jumping from one place to other, hospital hopping, doctor shopping, while the patient could have been at home comfortable and spending the having a reasonably good quality of life with his loved ones, and overall having good memories and having a good life, especially when there is quite a shortage of time. But this hospital hopping, doctor shopping happens, and a lot of money, energy, time, everything is wasted. Lot of family goes into poverty because they have to sell their cow, they have to sell their jewelry, they have to sell everything in the house. Finally they have to sell the house. They're literally on the road. I'm sure many of you are aware of it, that many of our patients had their homes of their own, but after a serious health illness, cancer including, many of them have to sell off everything that they have and then move into more compromised living conditions, rented houses, etc. So a lot of poverty happens uh, because we find it difficult to talk about these kind of issues. Then there is this barriers in relationship. The family members are not able to face the patient because the patient does not know what is going on. The family member knows what's going on, and they family members have to put on a mask in front of their face and behave as if everything is normal. When they get overwhelmed, then they goes to the bathroom and cry and wash their face and come back. In in short, A lot of drama is played and a lot of precious time is wasted. This was a time when there was an occasion to hug and cry and to tell that how much I love you, but that doesn't happen. So when the patient dies and the family member were to look at the photo of the patient with a garland and wishing, oh, if only if I had some more time. But what were you doing when there was time, when the person was alive? That time precious, the precious time was wasted in playing a drama. So all of these things happen because bad news was not communicated in time. Many a times we wait till the patient is very, very sick. So ideally, at every stage, from the time of the first visit, even before the diagnosis is made, the truth should be told. For example, this looks like something, it could be tuberculosis, it could be cancer, we'll have to find out. Let's take a CT scan. Okay, CT scan shows something like a tumor, it could be cancer, let's find out with a biopsy comes out it's like a cancer, let us plan for treatment. And the treatment is going on. I think it is spreading. So if at every stage, if you were to be truthful, honest, we'll not be having this big burden of so much of information to be conveyed to the patient at the very end stage where the patient is uh, almost unconscious or not in a position physically or mentally to deal with this kind of situation. That is precious time lost. So much of things that could have been done never gets done. So onus is on us. But many a times the family members create barriers. They come and tell doctor, please don't tell. Please don't tell the patient. So this please don't tell is basically the family trying to enter into a conspiracy of silence. Doctor, you talk to us, but don't tell the patient. So this is collusion. In our context, usually the family member comes forward to collude with us. In some countries, it is the patient who is colluding with the doctor, don't tell my family member. In our country, in our environment, sometimes it that also happens, but more or less the norm is the family coming and trying to collude with us to keep the information away from the patient. Now the family is trying to do this because they believe they are trying to protect their loved ones from harm, the harm of hearing bad news, and they're afraid that we as healthcare professionals may inadvertently communicate the bad news to the patient. So to preempt that, they come and talk to us, don't tell. So they try to enter into collusion. And if we try to argue with them, if we try to make them understand that no, 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 it's the right of the patient, or it's beneficial to the patient, remember they are coming to us in a high state of anxiety. So if we try to tell them that it is good for the patient, they will start panicking. Their anxiety will go up because they believe that it is going to harm. So first and foremost, we have to understand that we have to acknowledge that family members have beliefs like that, and let us not challenge their belief, because if you challenge their belief, they will only get more anxious. Does not solve any of our purpose. So how do we go about managing collusion? Agree to collude. You say, okay, fine, no problem. Sometimes I'll ask, what have you told the patient? And they say, oh, no, we told him it's an ulcer. And all. So I said, okay. So shall I also say it's an ulcer? So the family members calm down. Their anxiety level calm down. Remember, I am not playing a trick on them. I am colluding with them. So then I work with the family in caring for the patient and try to earn the trust. And one of the simplest and very powerful way of earning the family's trust is to make the patient physically comfortable. If the patient has pain, breathlessness, nausea, vomiting, constipation, insomnia, anxiety, if you uh, palliate these distressing symptoms, the patient is comfortable, patient is happy, is peaceful. That is very simple way to earn the family's trust. Plus you also need to listen to the family, listen to what their concerns are, listen to what their fears are, and all of these things will create a situation where the family trusts you trusts you, and now they are listening to you. So initially you listen to them. Now you have created a situation where they are listening to you. At this point of time, you can reorient the family towards why it is a good idea to communicate bad news. The 3 points which I just mentioned before, these 3 points. This is the time when you should be reorienting the family on why it is a good idea to communicate bad news. And you also tell them that even though it's a good idea, it is only applicable to those patients who really want to know. This is not something that you will push for every patient. And then you can also reassure them that the bad news will be communicated to the patient only with the family's permission. And within you, you have to understand that you are only a messenger of information. This cannot be your agenda. This communicating bad news cannot be your agenda. Because if you try to push it beyond a point and the family is still not convinced about it, you will see there's a friction in relationship between you and the family. It is not good for you primarily. Plus, secondarily, it is not good for the patient, because if there's a friction with the family, you and the family, there's a possibility that they will become a barrier to all the good things that you could do for the patient. Sometimes they may take the patient away from you also. So we just can't afford to have friction with the family. Plus, as I said, primarily it is not good for you because many of these patients will deteriorate and they will die. And sometimes if the relationship is not good, there's a tendency that you may be harmed in some possibly harmed in some way. At least you will not have peace of mind. So it's very important not to push this beyond a point. Coming back to communicating bad news, internationally there is a standard operating procedure called the spike protocol. I'm not going into the depth of it. It's just you know probably you are already aware of it. If you are not, it's okay, no problem. So just a small made-up story about Mr. Bharat, who is a 60-year-old gentleman. He had an abdominal discomfort and a weight loss of about 2 months duration. He initially went to the local GP, who gave him some, medications for 1 week, did not help, and he referred Mr. Bharat to the gastroenterologist in the city hospital, where he was evaluated. A CT abdomen showed a mass lesion stomach, and OGD biopsy showed this was a cancer. An exploratory lab was planned and done, which showed multiple peritoneal metastasis, and hence it was deemed incurable, progressive, advanced medical condition. It was just closed, and in the best interest of the patient, the doctor referred the patient to you for best supportive care. Uh, I I think that is the term that oncologists most like to use. They would not use the word palliative care. Sometimes they do, but many a times they are more comfortable with the word best supportive care or symptomatic care. So now you have the patient sitting in front of you. What do you do? So first thing is we need to find out whether the patient wants to know or not. Sometimes you may have a patient who say, doctor, what is my problem? Why am I not getting better? Then here is a patient who wants to know. Suppose the patient is the silent type, is not really communicative, then you may have to probe. The simple question, do you want to know? What's your problem? And if the patient responds, yeah, I want to know, that means here's a patient who wants to know. But question is, does this patient really want to know if it is something serious? For that, you need to give a warning shot. The warning shot, if it is something serious, would you still want to know? In Malayalam, I would say, കാര്യങ്ങള് ഇത്തിരി serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? In Hindi, I would say, अगर बात कुछ serious है, तो क्या फिर भी आप जानना चाहेंगे? Something like that. So give a warning shot, because when you give a warning shot, then the atmosphere changes. It becomes serious. It gives the patient a chance to back out if the patient was really not prepared for this, if it was something serious. So you may have a reaction like that. No eye contact. The patient may Change the narrative. Oh, give me some medicines, I'll come back after 1 week. Or the patient may deflect the question, tell it to my children. Or the patient may straight away say, I don't want to know. Or the patient may not say anything but not make eye contact. So the body language will tell you. If you have a patient something like that, do not proceed. That means this person is not really prepared to hear the bad news. And that is the patient's right. Not the patient has the right not to know. However, after giving the warning shot, if you have a person who looks into your eyes and says, yes, I want to know, no confusion here. This here is a person who really wants to know, no confusion. And now you can proceed. How do you proceed? You tell a story. Whose story? Of the patient, to the patient, from the beginning. And while you're telling the story, you fill in the blanks with information that the patient did not know. And while you're filling the blanks, you start escalating the information. Something like a shadow in their X-ray becomes a shadow. And the shadow in the X-ray becomes something like a tumor in the CT scan. And something like a tumor becomes a tumor in the CT scan, and hence sent for biopsy to know whether it was something like a cancer. And the report came as cancer. So something like a shadow becoming a shadow, shadow becoming something like a tumor, something like a tumor becoming tumor, tumor becoming something like a cancer. So you fill in the blanks and escalate the information. While you're telling the story, focus on the patient's body language, especially eye contact. If the patient's eye contact is gone, you pause your story because the patient may have received a new chunk of information. Patient needs some time to digest it before the patient comes back to you for more. So eye contact gone means probably patient is thinking about this new information. And then the patient comes back and says, okay, then what happened? Then you can proceed the story. Sometimes it's possible that the eye contact is gone for a long time and you are getting uncomfortable. You don't know what to do. Then you can ask, should I proceed? That will bring the patient back to you. And if the patient again makes eye contact and then say, yeah, you proceed. Suppose the patient is not making eye contact or has started changing the narrative, going to some other place, then that means the patient had enough, or at least enough for the time being. And that is the point where you stop the story. So either the patient gets 100% of the story, or 89%, or 74.2%, or 65%, that the patient decides. So how this is done? A small role play, telling a story honestly and with empathy. Mr. Bharat, you have been suffering from gas since 2 months, right? So your local doctor gave you some gas medicine and you said there was no relief. So he did an X-ray for you, and the X-ray showed something like a shadow. And you to know more about this shadow, he referred you to the city hospital. And oh, I didn't know that. Well, yeah. So uh, anyway, in the city hospital, the scan showed something like a tumor. And to know what this tumor was, they did this tube test called endoscopy. See, the eye contact is there, so we can proceed. The tube test was done to see if the tumor was something like a cancer. So that, do you mean to say that I have cancer? Uh, I'm sorry, yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? I'm sorry. When they opened you up, your tummy, they found that the cancer had spread all over. They could not really remove it. They lied to me. Now, here you see that the emotions have started, right? Now, when you are with a patient who is emotional, stop yourself from saying nice words of assurance. Because when you say, don't worry, we are there, no, 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 don't cry, basically, it will be like putting a cork back on a bottle which has just started flowing out, right? So it is very important for the emotion to flow out, because as long as emotions are high, whatever you say, whatever nice words you say, whatever plans for future you say, nothing is going to go in, because emotional part of the brain is a much stronger part of the brain than the rational part of the brain. So you have to allow emotion to be ventilated. So now I'm telling you to do something which is very, very difficult. We as doctors are not at all trained to do that. That is to do nothing. Just be with the patient. Don't say anything, don't do anything. If at all, you can just touch the patient for a brief moment, a human touch at the shoulder or at the knee, somewhere which is convenient, as the picture shows, for a moment. Just don't keep your hand there continuously. Just a moment, just letting the person know that you are there, you are not run away, and allow the person to ventilate emotion. This will not take 1 hour. This will take 1 minute or two at the most. But that 1 minute, 2 minute will appear like 1 hour to you, because as professionals, you are trained to do something all the time. Here I'm telling you, don't do anything, don't even say anything, just be there. You being there is therapeutic, because as a human being, you can ventilate only to another human being. You cannot ventilate to the wall or the furniture. You need a human being to ventilate emotion. So you be that person on whom the patient is ventilating. Once the ventilation part happens, there's a possibility that the person may say something with emotion. How much time do I have, doctor? Now remember, when people say something with emotion, they may have different reasons for saying the same thing. 100 people asking this question, how much time do I have, doctor, may have 100 different reasons behind it. I'm going to give you two reasons here. So here is one person who is saying, how much time do I have, doctor? And I said, do not assume. Instead of that, ask. Why do you ask that? My daughter's marriage is fixed after 6 months. Should I prepone it? So here is a patient who wants to plan. And that is why the person said, how much time do I have? Another scenario, same question, another patient, how much time do I have, doctor? Your response is same. Do not assume. Why do you ask that? Why did God do this to me? So here is a patient who does not want to plan. Here is a patient who is not done with ventilation. And a third person who says the same question may have a different reason for saying the exact same words. So what we have to understand is, when people say something in high emotion, don't assume they're saying this because of that reason. Just ask, and then once you know what they are saying, why they are saying, then you know how to react. And oftentimes it's just listening that is needed. So once the emotions have flown down, now you can finish the story. Now you can plan, you can talk about what is possible, what is not possible, and the things that are possible. Can it be done here? Do you need to go some other place? Approximately how much is going to cost, etc., etc. So all those things you can talk. Now remember, gone are the days where we used to practice my way or the highway. Now it is a participatory decision making. Most of you are familiar with medical board, tumor board, where different professionals bring in their expertise onto the table and a decision is made. But we do not include two very, very important professionals: the patient, who is a professional about himself; the family, who is the professional about their issues, family issues; finances, logistics, beliefs, everything. So these two professionals, that the patient and family, should also be part of the participatory decision making. Maybe not part of the tumor board, but definitely after you have a medical consensus of what is the medical best options for this particular patient's medical condition, now we need to have a discussion with the patient and family. According to us, this is the option that we recommend. What do you think about it? The patient says okay, fine. The family says no, 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 whatever. So there is a time to negotiate, talk about it, and come to a consensus, decision by consensus. Now remember, you may have the best treatment option, but if the patient can't afford it, or if there are logistical problem, your medical knowledge and medical participatory decision making counts for nothing if it is not accepted by the patient. You can have all number of tumor boards and give the best option, but if the patient does not accepts your treatment and just goes away, homeo, ayurveda, whatever, then what's the point of all the time, energy, and effort you have spent? So it's very important to include the patient family, listen to them, what are their concerns, what are their beliefs. Their beliefs may be from our point of view very immature or stupid, but for them it is important, and then negotiate. So probably the option that comes out of decision making, participatory decision making, may be the second best option, may not be the top option, but whatever it is, that would be practical because it will be acceptable to the patient and family. Get on with it. And last but not the least, always give achievable hope, but never give false hopes. So that kind of finishes our communicating bad news. A few words on anger. Now, I'm not talking about law and order situation because we as medical professionals are not trained in law and order. So what are the two law and order situations I can think of? Mob violence, a group of 10, 15, 20, 30, 50 people coming and attacking us. That's a law and order problem. Run away from that place. Another situation I can think of is if one or more people under the influence of alcohol or substance are getting angry and violent. That's a law and order problem because they just can't be negotiated with because they are under the influence. So when we are talking about managing anger in the clinic, we are talking about sane people getting angry, because people get angry not because today I woke up and I haven't been angry for a month, I am going to get angry today. Nobody wakes up like that. Many stress factors builds up, contribute to stress building up to a level where person loses control and gets angry. So being angry is essentially, it's an emotion. It's a negative emotion. It's a high energy consuming negative emotion, and that is why it is easy to control anger, because you just need to cut off the energy supply. So where is the energy coming from for anger? If you confront the person who is angry, you can increase the anger. If you ignore the person, you can increase anger. Confrontation may be in the form of argument, in the form of trying to explain, in the form of making excuses. All of that will be uh, taken as confrontation. If somebody is really angry, then even apologizing may make the person more angry. If you bring in another friend to try to convince the person, the angry person may feel that you are ganging up against that person, against him, and then the person may become more angry. If you do not reply to the person, if you turn away from that person, either because you are busy, you don't want to deal with this what's going on, so you don't reply, don't make eye contact, then that makes the person angry. If you're scared and do not want to confront this person, that will also make this person angry. So any kind of confrontation or any kind of ignoring the person, these are the two fuel supply. So we have to do something which is neither confronting nor ignoring. For that, body language is very important. So when you see somebody who's angry, you see that person will be so much full of adrenaline that the person cannot sit in a relaxed manner. The person is usually standing or pacing around. So basically, the person is in a standing position And if you are sitting, then your body message is going, I'm superior to you. So that person will become more angry, even if you have not said a word, you're not done anything. Just the fact that you're sitting and the angry person is standing creates more anger in the person. So you, when you see somebody is angry in your vicinity or directing anger towards you, you stand up, because that body language is showing, is conveying the message that I consider you as my equal. Then stand with a slight kyphosis. That shows I am respectful towards you. I'm not saying exaggerated kyphosis, just a slight kyphosis. See, body language can be perceived by the brain. It is, even without you knowing it. So just a slight kyphosis, you are showing respect. So you are showing equality by standing. With a slight kyphosis, you are showing respect. And keep your hands in front, because it is our primitive brain is very, very responsive to the perception of threat. So if you keep your hand behind, the primitive brain is anxious whether there is a weapon there. So if you keep your hands in front, the primitive brain is kind of reassured. No, this person is not a threat. So there also the anger comes down, because this person, you are showing this person, I am not a threat to you. I am not going to harm you. So in standing, you are showing equality, slight kyphosis, you are showing respect, and hands in front, you are saying, I am not a threat to you. I do not intend to harm you. Now coming to your face, eye contact. Make eye contact, because here you are showing, I am not scared of you. I am confident. Remember, it is, there's a fine line between becoming arrogant and confident. So you have a calm eye contact, not a staring contest. So a calm eye contact shows you are confident, you are not scared. And why should you be scared? This is your territory. So why should you be scared? So it should show in your face, it should show in your body language, but it should not amount to arrogance. Do not smile, because a smile will be taken as a threat. So keep your face serious. And then nod your head. For example, if normally when we are having conversation, we nod our head, right, upside down. In the South India, the head goes side to side, and right. So the further down south you come, it goes like this, side to side, and we will go north or east and west. It is usually like that. Right? So whichever way you want to nod, at least the person shows understands that you are agreeing with. The person may be saying bad words about you, but when you are showing like that, that means you are agreeing. So this is a kind of encouragement to allow ventilation of emotion. When you do this, we use this head nodding in other forms of communication. When you are having a one is to one interview with a patient, you want to encourage the person to give you more information, talk more freely, you nod and make sounds like so that person feels confident to talk. But whereas if you're an angry person, you're dealing with an angry person, don't make sound like that person. The sounds or smile will make the person more angry. Don't say a word, don't make a word, just nod your head. So we have talked about standing, slight kyphosis, hands in front, eye contact, serious face, nodding of head. With these important, positive, non-verbal things, without saying a word, a very angry person who is using expletives in high flaming anger, when you practice these things without saying a word, you will see the severe anger coming down. How will you know that severe anger is coming down from this position to this? The pitch of the voice comes down. It is high pitched, it comes down. The tone of the voice, from a very, very angry, menacing, threatening tone, it comes down to angry, but not menacing tone. And you will see that the words, the expletives, the bad words comes down. The person's words will turn more into complaining nature than threatening or, you know, casting aspersions on your DNA. So the kind of words, the tone, the pitch, everything starts coming down when you just practice all the positive non-verbal aspects. And once the flame has come down, you can see the person physically also calming down. The face, the body, everything, the muscles, the tension and all kind of comes down. It is not gone. The anger is not, we are not yet taken care of the anger. We need to take it, but at least the high flaming anger is come down to simmering anger. At this point of time is the right time to open your mouth for the first time and telling this person, I want to know more about this. Can we sit down somewhere and talk? Never invite the person to sit down and talk while the person is in high flaming anger. Just bring the anger down with your body language. And once the anger is now simmering anger, open your mouth and invite the person to sit and talk. And in the sitting and talking part, you maintain the same body language. That is, now instead of standing, both of you are sitting. You maintain a slight kyphosis while sitting because here your body is conveying, I'm here to listen to you. And keep your hand visible to the angry person, maybe on the table or holding it like this. Never like this. Never cross your arms around your chest because this creates barrier between the two people. It's all in the brain. The brain understands these things, these messages. So keep your hands visible to the angry person while sitting down. Now you're sitting down with a slight kyphosis. Keep your hands visible to the angry person and maintain eye contact. Do not smile. Keep the serious face. Continue the nodding. But now you can make sounds like, okay, then what happened? So now basically what you are doing is you are facilitating more ventilation of anger. Remember, anger management is like ascitic tapping. You don't punch the distended abdomen. You do not ignore the distended abdomen. You very skillfully put a small puncture through a needle and you allow the fluid to flow out in a controlled manner. You control the environment. For ascites management, you need a needle and a tube. For anger management, you use your body language. And you control the ventilation of emotion. Just like you allow ascitic fluid to flow, here you allow the emotion to flow in a controlled manner. You don't have to do really much. And once it is resolved, you can finish it in a good way. If there is a solution to the problem, you offer the solution. If an apology is due, that is genuinely there is a merit in apology, do apologize, but never give an insincere apology. Never apologize for the sake of apology because it is easily understood. This can sometimes reignite an anger, or at least it will leave the person with some irritation and bad taste in the mouth when the person goes away. So never apologize insincerely, never apologize for the sake of apology. If there is no merit, don't apologize. Only apologize if it is really merited. So you can say something like, thank you for bringing this to our notice. We are very sorry you had to experience this. So this is an apology. Another is a non-apology. Thank you for bringing this to our notice. This is what we will do so that so you can tell what are the things that you can think of, so that something like this doesn't happen again. So here you have noticed that you are finishing the conversation without giving an apology. So take home points after today's session, we talked about some general points, body language, verbal do's and don'ts. We talked about communicating bad news, collusion, anger. So sitting and talking gives satisfaction. On your day to day, when you go for rounds, whatever time you spend with your patient, if it is 2 minutes, 3 minutes, 4 minutes, whatever, don't spend more time, but whatever time you spend, just sit and talk, and you will realize that you are giving more satisfaction. Your patient and family will be more happy, and you will have customer loyalty, if I may use management jargon. Never assume. It is something that we do often. Always ask and ye shall be told. Focus on the family's distress. Many a times our focus is usually on the patient, which is absolutely needed. But when you see a patient's family anxious and distressed and requesting you not to tell the patient, please understand they are suffering. They are very afraid. They're anxious that their loved one will be told. So focus on reducing their anxiety, their distress. We can always work on the family, reorient them later after winning their trust. When it comes to communicating bad news, warning shot is the most important element. That is where the whole thing turns from a normal conversation to a serious conversation. Remember, as a doctor, you are only a facilitator of information. It is your patients who will decide whether they want to know or not. It is your patient who will decide how much they want to know. You have a lot of information, you have 100% information, but it cannot be your agenda to dump all this information on the patient. The patient picks and chooses whether they want to know or not, and if they want to know, how much. You just facilitate that information sharing. Emotion is something that we as palliative care professionals and you as oncology professionals will be dealing with very often. Remember, ventilation of emotion is therapy. Sitting and doing nothing, it is therapy. It is not a waste of time. And hope is very, very important. We live on hope, but we cannot live on false hopes. Always give realistic hope. And I can assure you, once you are tuned into palliative care, palliative medicine, there is no situation where there is no realistic hope that cannot be given. Always, always, there is something that can be given. Last two points on anger. Please, you are smarter than the angry person. You have to be really stupid to take the angry words personally. Because if you take them personally, you'll also become angry. And then it will be anger
Sir, it's 8
clashing,
o'clock.
and there will be total chaos. The last point is anger management is very simple. It is non-confrontational, active ventilation of emotion. It's an easy skill to master, not very difficult. So with this, I stop here. Thank you. Now
Uh,
back to, I hand the baton back to Dr. Ashok.
Thank you, Dr. Biju, for that wonderful session. We've already reached 8 p.m., so I think we'll restrict the questions to 1 or 2 questions. If anybody wants to ask any questions to Dr. Biju, you can ask either to him directly by unmuting yourself, or you can put it in the chat box.
Thank you for the nice comments. When you get compliments, it is food for the soul. It keeps us motivated to make this effort yet again. So thank you all for your nice comments. Really appreciate. Also be happy to take any questions.
So I have a question, sir. One of the main problems we have is communicating bad news. And on top of that, we have the added tension when this is, I'm sure that everybody will agree that we have a very difficult time with some patient parties who come in and tell us, please, at any cost, don't tell the patient. So this is something it's very difficult to overcome. And there are certain situations in which the disease is incurable and we know the patient is going to worsen, and when the patient is worsening, the if you have not told the patient in the beginning itself, the patient's apprehension is only going to increase. One of the things that I do is that I, at least by the second session or so, I inform the patient relatives that legally and ethically also the patient has a right to know. And if the patient himself comes and asks me, I can tell them, I can, in the first session, I can tell them, okay, I'll do what you're saying. I won't tell the patient party. But legally and ethically, if the patient is a sound mind and body, if he comes and asks you, doctor, what is my diagnosis? You have you are morally, ethically, and legally bound to tell your patient the diagnosis in, of course, the best way possible, in breaking bad, in the best way in which you can break the bad news. So, what's your opinion on this? Should we tell that to them, or?
Well, what you said is, for rationally, it is very correct. Only thing is that if our family is the patient's family is high strung, if they are severely anxious, it will not go in. So the way I deal with it is I just listen to them, give them more opportunities to ventilate their anxiety. Uh, Plus, of course, make sure that the patient is comfortable. You have a happy patient, the family, trusts you faster. So having those kind of skills, the palliation skills helps for you. If your patient is in distress, in pain, and that symptom wise the patient is not comfortable, the family will find it difficult to start trusting you in a fast forward. You make the patient comfortable, they start trusting you fast forward. The idea is that reduce the anxiety of the family. They will be more receptive to all the things that you said, including is the patient right, the patient, let the patient decide, that kind of things. You can have very often you have family members who are difficult to convince, and hence uh, when you are in this field of communication counseling, in the early stages of practicing counseling, it is normal to have more failure rates. But as you get better at it, your conversion rate starts improving. So just a matter of persisting with it. And today's session, it was, collusion was just one slide. When pre-COVID, we used to have workshops, dedicated to how to manage collusion with real, role plays and, situation. The idea is that we reduce the anxiety and kind of reorient and direct the family members in a skillful way so that they don't feel pushed into taking that kind of decision. Because if they feel pushed, there will be a pushback. That's what I'm saying. That can create a friction between our relationship, which none of us doctors can afford to have friction with the family.
Sir, can I ask something?
Yes, please.
Yeah, myself as a medical oncologist, I totally agree to Dr. Ashok, and your talk was very informative. I just keeping moving with Ashok's talk, Ashok's comment on breaking the bad news. As medical oncologists, when we are bound to give chemotherapy, we are bound to sign the informed consent, in which we have already made written all the stage, even not stage, in advanced stage, or there is a word called cancer in many of the sentences in which we do the informed consenting. So is it not better that we would give them not break the bad news all of a sudden, but give them at least that you have such a diagnosis, and then only what we are intending to do with the informed consenting, they would be accepting to that. Because further, without consenting, we cannot proceed. I think that same happens for radiation and of course for surgery, but some kind of surgeries, it's a diagnostic. So couple of times we come across such kind of dicey situations. The family asks you not to tell, but we are bound to take the consenting, where it is written cancer, 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 at least 3 or 4 times. So what's your opinion on that, sir? Because that's a really practical situation.
Right. Now, there are a couple of points that comes into my mind. In the ideal world, the first doctor who suspected cancer after initially trying out infection or TB and things like that, that primary treating doctor should have communicated to the patient and family, with the patient and family together. See, we have tried for infection, I have tried for this thing, I think it could be cancer, I hope it is not, but it is better, I'm giving you a letter, you go and meet the cancer specialist or the surgeon who will do it. So something like that. The honest sharing of information should have happened there. I'm talking about the ideal world. Then the person goes to the next doctor, finally comes to you. By the time, the whole journey of where they went first, then second and third, and how gradually the whole thing became clear. Though if in an ideal world the patient and family was given information truthfully at every stage, you would not be burdened with this kind of a problem to begin with. And hence, it is very important that right from undergraduate level, these kind of things should be taught. Communication skills, ethical decision making, all of these things is taught. But we don't live in an ideal world. So practically, what can we do? Whatever you are doing serves you fine. Obviously you are working and thriving, so it is working fine. The problem is, if you get into trouble, for example, if you find yourself in court in front of the judge and you show this document, "Oh, we have got consent signed on this piece of paper," and if the judge were to ask the patient or the family, or whoever is this thing, are you aware of this, and they say, no, nobody told us about it, they told us to sign and we signed, we don't even know what this is about, or even if you have told them, they can claim we did not understand what they are saying. So point is, ultimately the best defense, or the best protection for all of us, is to have a good relationship with the patient and family. The consent that you get on a piece of paper is, it has doubtful legal veracity, because it can be easily shredded as a piece of waste paper in the court, because the lawyer just has to say, my client did not understand the importance of it. It is something that was beyond their ability to understand. Even if they understood it, they were so in such emotional state that they were not able to. They can twist anything in court. So I'm saying is, by like an anesthesia, they say it is 99% boredom, 1% sheer panic, or something like the 90% boredom and 10% sheer panic. As long as things are going, it's okay. But if we get into trouble, then these things really matters, and we can't ever predict with which person, which patient, which family we are going to get into trouble. Hence the effort to talk, to convince, to win over, have a relationship, a trusting relationship, an emotional connect. All of these things are the real protection for each one of us. Hard work, but worth it.
Thank you, sir. Thank you.
So if there are no more questions, we'll wrap up the session for today. I hope you all enjoyed this session as much as I did. And so we'll see you next Wednesday. I apologize for not informing in advance that last Wednesday we had Republic Day and we didn't have a session. So next Wednesday, we'll meet you all for the session 4, that's Introduction to WHO Ladder and Non-Opioids. Thank you very much. Good night.
Thank you, everyone. So with that note, this is Ripriya along with Dr. Biju Raghavan and Dr. Ashok signing off from the Tips Echo Hub. See you in the next session. Till then, everyone stay safe, stay healthy, stay happy.